Good afternoon, and welcome to the first annual N. Putnam Kaleckas lecture. I'm Jules de Wald, the chair of the Department of Physical Therapy and Human Movement Sciences. This occasion marks the inaugural N. Putnam Kaleckas lecture in the department. The Feinberg School of Medicine is grateful to Mr. Kaleckas, as well as to N's friends and family for their extraordinary commitment to honor N's legacy of giving. N. Putnam Kaleckas was born in Chicago. She was awarded a Bachelor's of Science in Physical Therapy from Northwestern University in 1982, and a Master's in Health Sciences from the University of Indianapolis in 1990. Mrs. Kaleckas pursued her passion and worked as a physical therapist at Gottlieb Hospital, Baxter Healthcare, and a Naperville clinic before co-founding the DuPage Physical Therapy in 1996. Her practice in orthopedic and spine rehabilitation brought her much pride. After a challenging battle, Mrs. Kaleckas succumbed to multiple myeloma in 2004. Upon her passing, her husband, Mr. Richard Kaleckas, along with family and friends, chose to memorialize her life with the Department of Physical Therapy and Human Movement Sciences by supporting a yearly lecture series related to the practice of physical therapy. We are privileged to have with us as our first speaker for the N. Putnam Kaleckas lecture series, Dr. Shirley Sahrmann. Dr. Sahrmann is a professor of physical therapy and neurology at Washington University of Medicine in St. Louis, Missouri. In 1973, she was awarded her doctorate in neurobiology from Washington University School of Medicine. Dr. Sahrmann is a Catherine Worthington Fellow of the American Physical Therapy Association, the APTA, as well as the recipient of the association's Lucy Blair Service Award and the Marion Williams Research Award. She has served on the APTA's board of directors, many committees, task forces, as well as the president of the Missouri Physical Therapy Association. Dr. Sahrmann's research interests include control of movement, factors of affecting tone, and the classification of patients with movement dysfunction, from neurological lesions and with mechanically induced pain syndromes. In addition to her numerous national presentations, she has been a keynote speaker at the World Congress of Physical Therapy, the biennial Manipulative Physiotherapy Conference, and the Australian and New Zealand annual conferences. Among many faculty members in the program of physical therapy at Washington University, she was one of the primary initiators of efforts to conduct research, expand upon and teach the concept of diagnosis and classification within the program. She maintains an active practice specializing primarily in patients with musculoskeletal pain syndromes. The title of Dr. Sahrmann's talk today is Movement, a System and a Science, Importance to Physical Therapy. Please join me in welcoming Dr. Shirley Sahrmann.
One that hears what I have to say, which may be all right anyway. I can't tell you how delighted I am and honored to have this invitation to join you all. I knew before coming here the amazing work that was going on at Northwestern, but now I really know in spades. And I'm just relieved that I'm not going to talk about neurological things because I would be like so embarrassed by my piddly knowledge. So instead, I'm pulling an age thing. You know, when you get old, you're supposed to get wise. And so I'm, as you can probably tell by the title, doing a little bit of philosophy. It's my intention to try to give you some of the reasons why I think physical therapy needs to undergo a paradigm shift. And I hope that people will tell me where I'm off base or whatever. So, first of all, I was indeed impressed when I read about the mission statement for Northwestern University, because it's all about solving problems of human movement by educating people at the professional and graduate level, advancing the science and art of physical therapy through practice, education, research, and professional leadership, and generating new knowledge. And in a place with all the resources like this one, it's surely the place to do it. I was also further impressed as I read through the material, because clearly Northwestern has been a trendsetter, being one of the first 6 accredited schools, continually accredited since then, and you had early implementation of the master's degree and the doctor of physical therapy. So, and now a PhD in human movement science. And I thought, what an appropriate place to share what I think should be future trends with people that are already trendsetters. And the goal of your program, and particularly I was fascinated by the goal of the DPT program, is to add this additional content about differential diagnosis, health promotion, disease, injury, and secondary disability prevention. So my goal for this lecture is to add additional arguments in detail regarding the role of therapy in diagnosis, health, promotion, prevention of, I'm putting in there primary as well as secondary disability, and you'll see why, I hope, why I put primary in there. And that my really big belief is that the future for us is to be birth-to-death practitioners. I think that the profession needs desperately to be one that's more parallel in its care to the dentist, to dentistry, where people come in early and they're followed throughout their life by monitoring their dental system. And the other thing that I think we share in common, and I was a long time coming around to this, is that motor control is the key to both neuromuscular and musculoskeletal patients. So I'm throwing out these ideas, and they're really based, and this is actually my 50th year of graduating from physical therapy school. My wheelchair is waiting right out there. Where did the time go? Watch out, people. You'll turn around, I'm serious, you'll turn around twice and say, there goes 50 years, just like that. And if you have half the fun I've had, wow, it's a great ride. So anyway, the concepts that I think we're working on right now and that are sort of in place, and I want to address this really clearly, is that physical therapy addresses the cause rather than the source of a pain problem. In other words, I don't really care so much what hurts. I want to know, why did it get that way? That the other big factor is hypermobility. Accessory motion hypermobility is the primary factor in degeneration. And those 50 years have told me we're all degenerating. You know, it's going to happen to you too. It is happening to you too. As I mentioned, motor control is the key. Movement is a physiological system, and this is what I'm going to really try to sell you, and that we clearly need diagnosis of movement system impairments. And the nice thing is we use movement to treat. And that's great because it doesn't destroy your liver, your kidney, or give you heart attacks. Now, that's kind of where we are now. But the implications for the future are this birth-to-death practitioner. And the reason why I think that's so important is what we should be doing is guiding exercise and activity to optimize tissue generation and minimizing tissue degeneration. And that the public and the healthcare practitioners must become aware of the movement system. And they must consider us the absolute exercise and movement system experts so that we can provide guidance in motor control activities, strength, endurance, and postural activities, and for all individuals, healthy and disabled alike. And I think of what the profession has accomplished in the years that I've been involved, from a certificate programs to DPT entry level. You know, 50 years may seem like a long time to you, but we were slow getting out of the starting gate, and it's just amazing what's happened. You know, just for perspective, I didn't put that in there, but do you know it took from 1973, when we said everybody should go to the graduate level, until 2000 to make sure it was going to be the master's degree. Do you know that? And in this short period of time, bye-bye master's degree, here come the doctors. I mean, wow, that is amazing. No research or graduate degrees in movement science to PhD programs and grant-funded investigators. And you all are just the epitome of all of this. I went to meeting after meeting where everybody said, what is our body of knowledge? Those people in Iowa would come in all the time. What is our body of knowledge? I'm serious. We didn't know. Oh, guess what? It's movement. Wow. And when I got my first job, I really felt like a medical cheerleader. You know, come on, you can do it, let's go. I didn't have to think about much except, are they stepping on my foot or are they stepping on their foot? True. And now, here we are, diagnosticians. And I put question marks because it's not quite where I think it ought to be or will be. And one of the things that's so hard always is to overcome tradition or history. It's useful, but it's also a drag. Because what physical therapy has been historically is application of physical means of treatment. In other words, we were individuals with skills, but no content area. That our program was to rehabilitate people who were already injured. I was part of a study in the 1960s where they decided we were really technicians. I mean, that we were really professionals because we made decisions. I mean, they followed us in the clinic and they said, oh, you're deciding something. Ah, yes, I am. So we decided about the treatment, but we never decided about the cause, and we never decided about the need, just what is the treatment. And I'm here to tell you that our best kept secret ever since those days is that we make decisions. And that's a big problem. You know, it wasn't until 1994 that we got reimbursed for evaluation. Somebody else did that exam, so we didn't need to. Is that mind-boggling or not? I know we were doing it, but we didn't get paid for it. So, well, I know, it is mind-boggling. So movement science, well, how did all this evolve? And they were a cadre of very bright people that are in this room who said, you know, we ought to take this science and really study it. We followed the pattern of neuroscience. I remember that very specifically. People that were interested in the nervous system were in all kinds of other departments, and they said, we ought to get together and talk about our common interest, the nervous system. So, and there was also no home for systems investigators as time was going on. If it was larger than a membrane or a molecule, not too many people were interested. So we were able to, at least at Washington U, get people who were systems investigators and have them join us in a movement system pursuit. So, and I think most of the research that was going on, even in neuroscience, was, you know, how is this end, what's wrong with it up there, but not the specific characteristics of the movement disorder itself. So there was real clear need for people that were going to pursue the science of movement. I so agree with your statements. I mean, it's absolutely true. It's the primary science of physical therapy. And I know it's the core of the curriculum here. I've heard that in so many discussions today that have been very exciting. Now, you also have a motor control framework, and I couldn't agree with you more that this is where it is for every kind of problem with movement. You can't even make a muscle contract unless you got a nervous system, so I know it's really important. Okay, so your activities, your mission statement, etc., are all about disruption and movement, the mechanisms and characteristics, the inducing factors, and using movement for restoration and rehabilitation. And I'm kind of putting in parentheses, this is pretty much a focus on pathology-induced movement and dysfunction, and what I want to talk about is how movement induces pathology. And what about for prevention and enhancement of an intact system? So I have a little definition of movement science, the study of the mechanisms contributing to production of motion at all levels of the organism, the study of the effects of use, disuse, and alterations in movement on the tissues and systems of the body, and that incorporates all the anatomical, physiological, metabolic effects on bodily systems at all levels. You know, so we give up nothing, we just have a focus. So movement science, and I think the pillars that it sort of stands on are biocontrol, bioenergetics, and biomechanics. And the movement system, I think, has two big arms. And I think that from the day Helen Hislop coined the phrase, that she represented the traditional view of pathokinesiology. What pathokinesiology means, though, is how pathology induces a movement fault. And I think there's another big branch called kinesiopathology, and that's how movement induces pathology. Now, common to all of those arms are what we call base elements, modulators, biomechanical, and support. Base elements, the things you build on. Modulators are regulators. Biomechanics, I think, are the interface between the musculoskeletal and the nervous system. And cardiovascular, I know we have it, and I'm all for it. I don't know a thing about it. Just keep pumping, that's what I say. Now, well, anyway, that's the way it is. You can't know everything. Now, I looked up the definition of a system, and I think I won't read through the whole thing, but a set of interacting independent entities, real or abstract, forming an integrated whole. And the reason why I put this up there is I think movement so fits this definition of a system and its characteristics. So some years ago, Florence Kendall and I had the opportunity to put a definition of the movement system in a dictionary, so that made it a fact, right? You look up the facts in a dictionary, and that's where we put it. So it's a physiological, I'm not making it up, this is true, a physiological system that functions to produce motion of the body as a whole or of the component parts. The functional interactions of structures that contribute to the act of moving. Now, to me, that leaves nothing out. So if you want to talk about how air goes through lungs or something moves through a cell membrane, it fits just as well as how man moves in his environment. So it gives us an orientation, a focus, but it really doesn't limit us. Now, why is this so important that we talk about a movement system? Because, as I mentioned, if you look up physical therapy in the dictionary, which I hope no one does, it says that we use physical means to treat patients, which again says we have a set of skills, but it doesn't say we have a content area. And I'm just so keen that people have to recognize we really know what we're doing, not just because we're the best ultrasound people in the world, but because we really know what the conditions are. And that's what you're busy pursuing here in some ways, and I'm just trying to make it have real identity. So our content area is this movement system of the body. Why is that so important? Because when you look at the people that are highly recognized for their expertise, it's because they have specialized in an anatomical or physiological system of the body. You know, when you go to a neurologist, he's going to look at the nervous system. That's his job. If you go to a dentist, you know what their job is. Do you understand? To me, that's just critical that people can identify with the system of the body that you're supposed to take care of. And then I set this up because I think we should be doing a parallel to the physician. We have the movement system, a physiological system, and I've just picked on the neurologist, for example. They have their anatomical system. That certainly has some physiology connected with it. They have to know all about these things, the physiology, the pharmacology, the radiology that they can use. We have to know about multiple body systems as well as biomechanics. Now, the nice thing for the neurologist is they have diagnostic manuals. So they can go in and read about the diagnosis they have to know about, and they can read about the treatment for those particular diagnoses. So they have it easier. We should have the same thing, knowledges of the dysfunctions of our systems. And I said one of the good things for us is that we can treat not only the result of a source of a problem, but also the cause, while the neurologist looks at the source of the problem. And I'll explain better. Our treatment can be by using movement, which is really nice. And also, we could have a big role in prevention. It's much harder for the neurologist, or now we can get the neurosurgeon, because treatment is logical. Opportunities are limited. Okay, so a little bit of clarification of cause versus source. And I'm doing this first from what I call the kinesiopathological model, so the musculoskeletal patient. Source is what tissue or pathoanatomical structure is symptomatic. You know, that's pretty much by guess and by golly. And I always like to use these examples of years ago, you had anterior hip pain, and it was called iliopsoas tendinitis. Now we know it's probably not an itis at all, it's probably an osis. But since we're not sure, we call it apathy, which means something's wrong. You know that's true. And now it's probably a tear of the acetabular labrum. And probably the things that we did to treat those patients are totally contraindicated. Now, patellofemoral dysfunction, and I know you're studying this, and we've taped the knee and we did all kinds of things at the knee. And now, of course, what Chris Powers and other people are showing, we should have been taping the hip because the problem is there. The cause is at the hip, not at the knee. So identifying where it's hurting is not necessarily the most useful thing. You want to know why it's hurting there. So the cause is the mechanical factor, and I'm going to say the movement that irritates the tissue. So I think also in the pathokinesiological model, and you all can tell me this because I just thought this out for the first time getting ready for this, that you have a source again like the nervous system, and you have a cerebral vascular accident, and the physician's sorting out whether it's a hemorrhage, an emboli, thrombus, or just where it is. And we're looking at the result of that. So that pathology induced a movement deficit. So we're looking at sort of a result of the source's problem. And what I've discussed with some people, because again, I probably should be medicated for my obsession with classification and diagnosis. I'm not, but I should be. I'm very keen that in physical therapy that we develop these diagnostic categories that direct our treatment so that we can have the same advantages that the physician practitioner has for a lot of reasons. But okay. And then just to show you the level of diagnosis that I think we should be doing, this is the sort of NAGI World Health kind of scheme. And in this scheme, the real scheme, you have disease and pathophysiology that results in impairments that causes functional limitations and disability. Now, clearly, these are systems that have developed a pathology, and those should be diagnosed by the physician. I have no doubt about that. Now, and those would be the pathokinesiological conditions. But the kinesiopathological conditions are how impairments lead to disease and pathophysiology. And I've put up here two examples. The metabolic syndrome, which we know is leading to heart disease and diabetes, and repetitive use syndromes. They're all impairments that result in disease or pathophysiology. And I think that the level of the impairment, that's where the movement system is applicable, and we can make our diagnosis there. We're not making the same ones the physician is making because we're not doing a systems pathology. We're doing an impairment problem in our particular system, the movement system. It just seems like, oh, well, that's reasonable. At least I think so. I put this up here to remind you, I don't think we should be talking physical therapy, diagnosis for physical therapy or PT diagnosis versus medical diagnosis. We're all medical. And that's why it should be the movement system versus the nervous system versus the orthopedic system, if that's clear. Okay. So I think we need movement system diagnosis for effective treatment, for research, and for recognition of decision-making responsibilities and capabilities of the physical therapist. And as I mentioned to you before, I think that's one of our best-kept secrets, that we really figure things out and that they can be labeled. And they need to be labeled. Okay. So what are the decisions that PTs have made over the years? And again, this is sort of a historic thing because I am so old, I actually saw polio patients. Do you know what that is? Polio, you've heard of it? Yep. Well, it was nice then. Things were easy. They got weak and they developed contractures. We kind of think we knew what was going on until Sister Kenny called it spasticity, and then it got all messed up. But anyway, it's true. And so we knew kind of what we were treating. We understood the mechanisms. And then things got bad. When we started moving on to the neurological patients, we didn't know what was going on. And I think the sad thing was, it was a necessary thing, but the sad thing was now treatment was decided by the system of treatment rather than the underlying condition. Well, we didn't know what it was, and we still don't know what it is, so I guess it's okay. But unfortunately, it started a bad trend because the cause célèbre in physical therapy became, what system are you using to treat people, rather than what's the underlying mechanism problem here. And so, and again, because all of these patients are much more complex, that we need to put them into some kind of patterns so that we can all recognize them and build on them from there, because there are no guidelines right now. Okay. Now, neuromuscular conditions, the treatment decisions are guided by this modification of treatment for lower motor problems. Then by PTs, as I'm saying, just a little bit of repeat, developing systems of treatment. And I know now we're using things like treadmill training, constraint-induced therapy, so they're modes of treatment. And I think, again, that those outcomes would be better if people were put into categories to use on treadmill. You can't take all hemiplegics. I spent 9 years treating hemiplegic patients. They are not the same. I know one side doesn't work as well as the other, but there's a lot of differences beside that. So one of my colleagues, who unfortunately is not working at Washington University anymore, Patty Sheets, has done a really yeoman's job in trying to spell out some impairments for the neuromuscular system. Okay, now what about musculoskeletal conditions? I think, again, decision-making for treatment has been guided by our historic role of trying to decrease inflammation of acute condition or joint dysfunction. And the treatment was for the source of the pain. What tissue hurts? I'd like to believe that what we're trying to do is evolve this to the understanding of causes. And as I alluded to before, I think musculoskeletal pain is part of our progressive degeneration. You just wear out. It's a lifestyle problem combined with genetics. And the underlying feature, the underlying cause, is the repeated movements and sustained or prolonged postures of everyday activities. I'm going to try to do this. So all joints, and the other generalization is that degeneration is a problem of hypermobility. Accessory motion hypermobility. That's what makes joints in places wear out. And that this primary dysfunction, when people come in with pain, is just the acute pain onset of what is a progressive condition. I don't think any of us treating musculoskeletal patients think, oh, the pain's gone, now you're 100% the way you were when you were 21. We know those tissues are just not the same, or the incidence of back pain wouldn't be 80%, et cetera, et cetera. No, we know it's something different. So the big thing, and that's why I decided to put an emphasis in what I want to show you on motor control being the factor. So I just have these pictures, and I'm going to show you these things. Now this was, these men, that when I took these pictures, they're probably on Medicare now, but this was the first, that's why it's in black and white, you know, and they aren't digital. Anyway, this was my first real insight into, oh my gosh, two people doing the same thing don't do it the same way. Oh, that was like interesting. I'm just going to show you this. And then I put on here, as you all know, there's a force couple that controls posterior pelvic tilt and another force couple that controls anterior pelvic tilt. Well, again, you can run it from one extreme to the other. So the fellow here with the poor posture, I submit to you, he uses limb muscles. That's why he has a poor middle, and it's more than his transversus. And this fellow has good posture, and he uses his trunk muscles instead of his limb muscles. And I'll just show you this little bit of, so they do forward bending, and he doesn't go very far. He's pretty stiff, and this doesn't look too bad. And did I go forward? No. There we go. Now, here's the EMG. We have an electrogoniometer on the hip, and just to show you, this is the first fellow, and what has he got? Continuous hamstring activity and an asymmetry between left and right, very little back extensor activity. This fellow, very little hamstrings, rests on his ligaments the way he should be, and then he gets a big burst, not just in the hamstrings, but the back extensors. In quadruped, this is a carryover from the old days of retraining the nervous system when you had a stroke, but it really is useful. So, again, different alignments. I won't go through all the details. He doesn't go back so far. He does. He's going not so far forward. You can see him contracting all of his leg muscles, and this is a full excursion. Look at the EMG. Hamstrings, no back, no hamstrings, back. Two people doing the same thing. And then here's another. Now there's supine doing a straight leg raise, and we have a force detector under the left foot as they do a right straight leg raise. This fellow's doing what? Hip extension. And why? He doesn't have any abdominals. This fellow doesn't do his hamstrings for the posterior pelvic tilt. He uses his pelvis. So two people doing the same motions, slightly different, but fully reflective of different motor strategies, but ones that you could predict by looking at how they're built. Oh, and we actually documented that if you do a natural strategy of hip extension, you use your abdominals significantly less than if you don't do hip extension. So it was so nice that the research supported the kinesiology. It's so good. And then just to show you another thing about why this whole musculoskeletal thing, I think, is so related to motor control. These are 3 ways of returning from forward bending, and these are basically motion analysis markers on me as I go through 3 things. And this is primarily hip extension. This is the safe way. This is back extension followed by hip extension, and this is ankle sway. So just to give you an idea of what this looks like, this is, I'm going to be doing here hip extension twice. That's hip extension. You see hip extension again. Okay, now watch the next one. That's back extension. Now, which patients do you think, well, we have patients classified into patients with an extension syndrome versus a flexion syndrome. Which patients do you think return from forward bending by lumbar extension primarily? Extension patients, of course they do. But I don't want to do that again. Now here's lumbar extension versus, that was lumbar extension. Now ankle sway, sway back, sway forward, sway back. Now which patients do that? The ones without hip extensors. So the strategy, and it's self-defeating, because if you stand sway back, your gluteals go away. I call it missing for lack of action. And because all those involved in rehab know, when we used to walk the paraplegics, we say sway back because you don't have any hip extensors. Rest on your Y ligaments. Now I'm so glad they didn't have sensation, because these would have been hurting. But anyway, that's true. But it decreases the use of the gluteal muscle, so then you don't have them to use to do the other. So these strategies, you only change by teaching people to do it differently. It's a motor control thing. But yet it's the difference between back pain and no back pain. And then this is a patient with back pain, and just to make the point that when he bends over, it doesn't look so bad, but when he comes back up, that is lumbar extension. So if you do this all day long, your back is going to really ache. Now, how do you change that? You teach him to do it otherwise. It's a motor control problem. Oop. And this girl was essentially discharged from the military because she said she had back pain, and they said, oh, no, you don't have any back problems. And I want you to watch her side bend. You see? You see? But there was nothing radiologically wrong with her. She couldn't have had back pain. Does that scare you? Yeah, it scares me too. That is so bad. I mean, if you heard the video, I'd say, oh my God, that is so good, it's so bad. Now, I'm not going to go over the research that Linda Van Dillen's doing, but I thought I'd just show you that using motion analysis now, we've been able to quantitate all of these things that we just look at and say, oh, that's really bad. And Linda's doing an amazing job of, you see, that would be somebody that is side bending, much like the woman that I showed you. So we can quantitate these movements now, so we can look at the musculoskeletal aspects. Okay, so I'm trying to make the cell. It's the movement system that's our primary responsibility, and it is wearing out. And what we need to do is guide people in the activities between those that optimize function and those that accelerate the degenerative process. Now, this is another young man who for 2 years had interscapular pain, but he had no diagnosis because there was no tissue problem. And I just want you to watch this shoulder. But there was nothing wrong with him, and that was the really good news. Now, I put up here, and just to show you this is so totally a motor control problem, this man was a right-handed laborer. What would a right-handed laborer do with his left arm? Hold, 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 and that's exactly what he did. And so the treatment was, don't do that. The treatment was, he had to learn to turn off his scapulohumeral muscles more rapidly than he turned off his serratus anterior. So this is 2 months later, his 3rd visit. This was intensive physical therapy. And all it was teaching him, let go here, let go here. Don't hook these up and keep them wired. You get what you train. You get what you train. And the body doesn't say, oh, but that isn't right. It just says, I'm going to do whatever you train me to do. And it sets up a pattern, and then it feels right. And I put this guy on. He's actually a physical therapist bodybuilder, but you think he's going to be a governor somewhere soon. And he has a beautiful serratus anterior. Isn't that gorgeous? I mean, the rest of them's not bad either, but but what I want to show you is he can do. I know, there it is, working. Now watch what happens on this sequence. Watch him tighten up here. See those? Watch him set them. And now you know what's going to happen. He's going to turn off the serratus, and you know what's going to happen to his scapula? It's going to wing. Sure. And my point is, he knows what he's doing. The patients don't know what they're doing. And those are the patients that have pain when they bring their arm down, not when they bring their arm up. So I'm just showing you that it's a motor control problem. It's not strengthen this, it's not stretch that, it's teach them how to do it. And I just thought I'd just show you that if you go through the literature and you read about what people write about degenerative disorders of the spine, 3 main phases: temporary dysfunction, that's the acute pain that they come in with. Segmental, these are not my words. Instability, I don't use that word. Hypermobility, and the last stage is, guess what? Hypomobility. So the stages 1 through 4 are hypermobility, and there's actually gender differences, and we're finding that in our studies as well. And by the time you get to hypomobility, it's over with. It's over with. That's good. And the theoretical scheme is facet joint synovitis, hypermobility, progressive degeneration. I love what they say here. The natural consequences of aging and the repetitive trauma of normal activity. Now, the quotation marks are mine. It isn't normal activity. It's a strategy that's not appropriate, that they can be trained out of. Facet joint change, intervertebral disc degeneration, et cetera, et cetera. Subluxation of the facet joints. Well, I could go through all the details of how this works and why it works, but the big bottom line here is that you don't treat just the facet joint, you don't treat just the disc herniation, because they are just 2 components of the motion segment. All of them have undergone changes. It's not just this one segment. So the best you can do is stop them from destroying themselves. Now, here's an example. I thought I'd give you real-life examples. This woman has back pain. Now, watch her walk. You are watching her walk. But tell me whether you think she meets our kinesiological standards. How much should the pelvis rotate about a central axis when you're walking? I think it's like 4 degrees in one direction, a total of 8. That means if you can see it, it's too much. Now, do you think that has anything to do with her back pain? What's the worst thing you can do with tissues? Alice and I were talking about shear. What do you get shear from? Rotation. So I call it the tail is wagging the dog. She's moving her pelvis. Now, does she have predisposing factors? Yeah, she has a wide pelvis. And the wide pelvis with the prominent trochanters and the genu valgus probably says she has coxa at the hips. So if she sleeps on her side night after night, she's in a horrendous side bend. If she goes to roll over, her upper body will make it about a half an hour before her lower body, because she's got to have all that come along. I'm serious. You know it. And then I'll just show you. Look at here she is. This is the same person. Now, she works as a pharmacist in the operating room. Okay, rotation right, rotation left. Now, how do you think her operating room is set up? Oh, really? Do you think it's on the right? The body is a roadmap to how it's used. And now I'm just going to ask, look at how wide that pelvis is. You realize what kind of side bend she's in all night long, year after year. I'm going to ask her to do hip lateral rotation. But what is she rotating? Her pelvis. Now, she can do it otherwise, but the easiest thing for her to do is to rotate her pelvis. Oh my gosh, Shirley. Now I'm going to have her, flex her knee, and I'm just going to show you when I passively flex her knee. I'm checking to see if that's lumbar spine. No. Anyway, passively flex her knee, what moves? Her pelvis. And why does her pelvis move that way? because her back is so flexible into rotation that the stretch of her tensor fasciae lata iliotibial band causes it to rotate. And then I'll just move on in the interest of time. If we do hip lateral rotation, do you expect her pelvis to rotate? Of course, because her back is so flexible that any of those movements, you know, the big rule is, and I didn't even put it down here, is the body takes the path of least resistance for movement. So wherever it moves, it's going to move because it's the easiest. So Linda and her graduate students are, again, quantitating these things with motion analysis, and we have a finding that people with back pain have more lumbopelvic motion during knee flexion than people who do not have back pain. We're trying to, one of the things is to look at the theory, the same thing here. There are gender differences, actually. Men have more movement of their pelvis with lower extremity movements than women do. And it makes sense because their musculature is stiffer. It's stiffer. It's not that you can stretch it. And then I thought I'd throw this in because I know there's so many. This is a physical therapist who treats neurological spinal cord injury. And what I'm showing you, she's trying to hold her hip in abduction. She cannot. She cannot hold her leg up in abduction. But do you know what muscles are incredibly strong? Her adductors. And why? If you treat spinal cord injured all the time, what do? You stabilize by holding your legs with your adductors. So the adductors get so overdeveloped, the abductors say, well, okay, you guys do it, rather than the abductors, combined with quads and hamstrings stabilizing the pelvis. You can see the other leg. She's trying to hold it up. She's getting a cramp, but she can't. See? You get what you train. You get what, you know, I was so long figuring out that the muscles didn't take kinesiology. They didn't know the. And then just showing you, if somebody steps up a step and their knee is like this, you expect them to get knee pain as compared to if they step up like that, an everyday activity. And this girl's going to stand on one leg. Can you see what happens at the knee on the right? Medial rotation and knee hyperextension. But here we come with the cure. We say, don't do that. Contract your buttocks and prevent the knee from turning in. So you changing the performance because otherwise she's going to keep hyperextending and medially rotating the knee. And then I just thought I'm not doing too bad. I'm racing through this because I'm trying to give you the big picture of all of these things. So this was an Olympic level marathonist, and she was actually had knee pain. And I always like to say, I want you to figure out which knee. And she had been going to physical therapy and getting ultrasound treatments. And in 10 days, she was to run relays around the Great Wall of China. And she said, Shirley, if my knee doesn't get better, I'm not going to be able to run my relays. And she said, maybe you can take a look. And I said, fine. So I'll give you a close. Oh, I didn't put the other one in. Let me back up. Can you just look at her and figure out which knee it is? It's the right knee. And what it looks like, I hope to you, is the femur is going anterior medial while the tibia is going posterior lateral. And the structure that's sort of problematic that's the biceps femoris there. It's hypertrophy running from the ischial tuberosity to the head of the fibula. Okay, we'll take it on. And look at the medial rotation of that leg. In fact, even in, I didn't put the sitting one in. Even in sitting, you could see it. So when she stood on one leg, which happens often when you're running, she had an increase. And the whole treatment is on the next slide. I told her, tighten your buttocks and keep your knee going straight ahead, rather than having your knee go into varus. And she was able to, we practiced walking around the department for 20 minutes, and actually, I never saw her again, but she wrote postcards and called me on the phone. She was able to go to China. She was able to train in our Olympic training center all summer. She said, Shirley, if my knee hurts, I know I just need to tighten my buttock more. It's a motor control problem. And the pain at the knee, the ultrasound was on the source, but it wasn't where the problem was. The problem was in her hip. And this could come on the right leg because she slept on her side with her leg draped across her body in adduction medial rotation, stretching out those little deep lateral rotators. Okay, this is to show you the difference between corrected and not corrected. Okay, and then just to make this other point, maybe because I am getting, I'm not focused on this old bit much. But you can't pick up a paper that doesn't tell you about the benefits of exercise. In fact, I had a friend that was tested for memory loss, and this just blew me away because go through all the tests, and they said, yes, it's happening, and here are the pills to take. And I said, well, is there anything else, like brain games or whatever? And they said, oh, I'm glad you brought that up. Do you know what has been shown to be the most effective in slowing down the progression of Alzheimer's disease? 30 minutes of aerobic exercise 3 times a week. Was that mentioned first? No. And then what else do you need to know? Well, you can't just go out and do that unless somebody can protect your musculoskeletal system, or you won't be doing it long. Do you understand? It's a twofold thing. Not just go out and exercise, but does that person directing your exercise program have enough expertise to know you won't injure yourself, or how you need to do it if you already have bad knees or a bad hip? I mean, to me, it's like, wow. And this was an afterthought rather than a first thought. So there it is. Exercise is like the secret to a healthier life and maybe a longer one. So I'm just throwing this out there that during childhood, we should be monitoring people. If we worry about how people's teeth come in, why don't we worry about how their body works? That's the least we can do to help them with this. And monitoring structural variations, and I'm just going to show you these, that actually contribute to problems. These boys, yes, were playing soccer, and their coach decided their adductors were short, and they needed to stretch their adductors by pushing down on their knees. Now, those of you that do pediatrics can probably recognize that guess what these boys have? They have femoral anteversion. They were mirror image twins, and they have mirror image anteversion. So they would have just pushed those hip joints into a real labral tear in short order by stretching those short adductors, which is a structural problem. And now they're finding the hip joint is the new big thing of interest, and now they're finding out that the head of the femur can be too big, or the acetabulum can be too big for the head of the femur, or the neck is too thick, etc. This is the son of a physical therapist. He had hip pain. She noticed that he couldn't flex his hips, and indeed he played basketball, and he couldn't go sideways like this. He went like that. So she started trying to stretch his hips. Now, they don't think this is what caused it, but you can see he has fractures at the acetabulum because the head of the femur is too big. Too big, the neck is too thick. So with any kind of hip motion or abduction, he was banging away on the acetabulum. There are so many of these out there, so many more than we ever thought. And people trying to mobilize a hip. Okay. This is a tennis instructor. He's a little bent out of shape. I know. I thought he would have all kinds of problems. He had jaw pain and neck pain. Now you say, oh, of course he had neck pain. But I just want to tell you this. This fellow, and it's a good thing I got this picture here, because he kept his head like this all the time. I even went and stood over here so that he would have to turn his head, and he went like this. And if I turned his head like this, which was easy to do, there was no resistance, in 2 seconds it went right back like that. I'm kidding you not. If he tried to turn it, it would go like this. But I could easily go this way. And you know what else was interesting? If I put him in quadruped, he could turn. He couldn't do it here. And you know what it was from? 300 backhands a day. You know what the cure was? I kid you not. I kid you not. I kid you not. Okay. So just a little flavor of trying to pick up some structural things, guide people through teenage years, young adult, old age. And this girl, just a couple more, and I think I'm doing pretty good here. She had femoral anteversion. Wasn't very severe, but she had some, and she was a ballet dancer. Actually went to physical therapy school. We're doing the hip flexor length test. Where's the path of least resistance for her? She got her turnout because she couldn't get it at the hip, so she got it at the knee. In fact, she could do this. Now, I think we should be screening people if you have in femoral anteversion, nevertheless acetabular anteversion with femoral anteversion, you shouldn't be doing ballet. I mean, you want to do it, it's okay, but don't look for the turnout because you're going to get a new hip by the time you're 50. I kid you not. Men that have retroverted hips, you can play golf, but you better turn your feet out first because otherwise you're going to have a labral tear. if you have your feet going straight ahead. The kickboxing, the dancing, the cheerleading, people ought to know what they can or can't do. And they say, well, you know, people ought to be able to do what they want to do. And I said, I wanted to be tall and beautiful, but it didn't happen. So, you know, it's the way it is. And of course, this was her sitting posture. I should have been Norwegian, then it would have worked. Anyway, so I'm suggesting to you for lots of very practical reasons that they need us to guide the movement system from childhood on up to seniorhood. And we should be, and I'm saying this, and that I know, I didn't say this initially. I was told by a physician, physicians are not doing physical exams. They're radiology dependent these days. And they're using nurse practitioners and physician's assistants. And I put in here, my uncle got a new knee for his spinal stenosis. And I've had many patients since then. He had a pain in his knee. He was old. He went to a knee doctor, and the knee doctor said, well, your knee is worn out. No wonder you got a pain in your knee. It's just he couldn't walk 6 months later. And as soon as he finally called me, and said, well, he was in Florida. We're all good St. Louisans go in the winter. And he finally said, Shirley, I've got this wonderful knee. I just can't stand and walk still. So we did this. Oh, it's gone now, huh, Dave? Yeah. Oh, back. So we spent about 45 minutes, and he hasn't stopped walking since. Now, I'm not saying he also had been to physical therapist in 2 different states, and they just did the protocol for the knee. They didn't bother to sort out why it was still hurting, et cetera. So I think the other side of it is, too, there's lots of mechanical problems that aren't being identified. They're being treated as diseases, and I could go on with story and story after that. Why don't they get referred to us to be identified for a mechanical problem once they've ruled out disease? Because they don't know that we can figure these things out. So I'm proposing that we should become the family practitioner, consulted for physical exams during the early years, return for yearly checkups, posture, strength, endurance. I've seen musicians. I saw a 16-year-old girl labeled as fibromyalgia. She was a flute player. And, you know, if you play the flute, and how much air does a flute player? They move as much as a tuba player because half of it goes over the instrument. She had abdominals that were so short, they were compressing her neck and her rib cage. And her head was stuck off like this. She no more had fibromyalgia than I do. She had a head that wasn't on right and abdominals that were too tight. So they should see us. I don't want to be there counting to 10 while they do their exercise program, but I want to be the one that consults them. And I can't tell you, I don't usually go to gymnasiums unless I have a lot of cards to take because it's too disturbing. But I have been told by many of my patients, do you know how many disabled patients are going into fitness centers and gymnasiums and being taken care of by personal trainers? Now, I'm happy with that if they know the rules. If they know the rules. Okay. So, the future of PT, consulted by patients and other healthcare practitioners for diagnosis. They ought to know that we can label a condition, recognize a pattern, and for potential signs of pending dysfunction. The nice thing about sort of this thing of the musculoskeletal system in this way is that there are signs before there are symptoms. We can see things that are going to make it become painful. And care of patients for rehabilitation of pathokinesiological problems that I think should go on monitoring forever. Absolutely. I also believe that reimbursement's going to change for us. I think they're going to come down on us just as they did a few years ago to start cutting things, and that it's going to get harder and harder to get paid for intensive care over a short period of time. And that we should be looking at reimbursement spread out throughout a lifetime, rather than you get so many dollars to take care of this person right at this minute. So I also propose that we ought to have diagnostic manuals with accepted lists, just like the neurologist has and the orthopedic surgeon and everybody else, and that treatment's based on movement system diagnosis. Of course, it will vary as time goes on, and people like yourselves analyze those categories and make them better. We should be out there slowing down the degenerative process, addressing hypermobility versus motor control strategies to slow the path to hypomobility. And that's it, and I thank you very much. I was worried it wouldn't be too scientific, but it was okay. It's good. We said if there was enough time, and I sped through it. Is that all right? Are there questions? I mean, you want to tell me I'm crazy, or is there not time? There's one way up and back. Just shout. I will say, after 50 years in this profession, I have never been more excited about what the possibilities are for physical therapy. It's just all out there for us to jump onto. It's such a wonderful profession. Well, you all know that, or you wouldn't be here.
So my question is that many times it's the pain that motivates the patient to comply with their treatment.
Yes.
And so, once they start feeling better, they many times don't continue the recommended treatment. And so what are your suggestions?
That's the way it is. The big thing is I still treat patients. I'm still practicing trying to get it right. And that the way my treatment goes with, the honest answer is I do not treat patients. I teach them what to do. So I show them how to move so it doesn't hurt. And then the way they do it does hurt. Now that helps a whole lot with the initial compliance. And I would say that for the most part, most patients say, and I'm very reasonable about what I want them to do. I incorporate it into everyday activities. Like, you're not going to get out of the chair going like this. You're going to get out of the chair going like that. Okay. And so most people say, I guess I'm going to have to do these the rest of my life. And I say, that's long enough, and don't call me after that. And I think the other thing that's important to convey is it's not sad that you have to do this. You're the lucky one who knows what to do. And I'm not asking you to spend any more than 15 or 20 minutes doing these things correctly. Plus, if you incorporate it into their everyday activities, it becomes part of them. And then they know if they hurt again. I often get calls, can you send me another copy of those exercises that I got, So, my reminder is you can't control people. I know people still smoke. Don't you? Do you know what I mean? And if that doesn't scare people into doing the right thing, then that's their problem. Okay. I don't have any problem saying it's your problem, not mine. I don't have any pain. Anything else? You got a question? Oh, good.
Thank you, first of all, for speaking to us. I really appreciate that. I have an article actually in Spine by Fritz, and it has low back classifications. Yep. And I was just wondering if you're familiar with them, if you think that's a good step in the right direction, and if you had any other classifications for any other type of pathologies.
Yes. Now, I don't know which, the Fritz and Delito and them have done a treatment, TBC, they call it treatment-based classification, and they also have the clinical prediction rules. And the clinical prediction rules are really a prognosis thing. They're not a diagnosis thing. They're under what conditions will people get the best outcome. So it's not truly a classification. And the treatment-based classification, I'm all for anything that's putting people into a classification. Personally, and actually Steve Rose some years ago sort of started that direction. And I think my problem with using treatment names is, will there be one called Swiss ball? It's that it's self-limiting in the interventions, and I'd rather try to spell out. So we have, would you believe, flexion syndrome, extension syndrome, flexion rotation, extension rotation, because those are the movement directions that cause the pain. And I'm not doing a explanation of all this now, but I think if we have those classifications, we can know better how to treat them. And the treatments will change over time as we understand the mechanisms better. So classification I'm super happy with. I might choose another route to it. I say the other thing that's very different between their approach and ours is I care a lot about mechanisms and they don't. They're not looking at the mechanisms. They're looking at outcomes. And I'm like a mechanism person. I couldn't do anything if I didn't have some understanding of what's going on, even if it's just rudimentary. Yes. Oh, Peter. Uh-oh.
No. Shirley, I really enjoyed the lecture. It was terrific, and the overall perspective. I have two questions if there's enough time, if nobody else has a question. But the first one is on diagnosis.
Yep. Oh, good.
And that's a really difficult issue because, in fact, I was involved in negotiating with the Medical Society here in Illinois over that issue legislatively when we tried to get the concept of a diagnosis into our Practice Act, and they were resisting.
Yep.
And as I was studying that issue prior to those meetings, trying to come up with some explanation that would be helpful, talking to the physicians and to legislators, one of the issues that kept coming up, even in trying to adopt the concept that you were bringing forward of a movement system diagnosis and what is unique about a diagnosis that is appropriate for the physical therapy scope of practice, was even if we have movement system diagnoses, we're still as an orthopedic practitioner, I'm still going to be treating patients with a diagnosed herniated disc or a torn meniscus or a fracture of some kind, and it's now post-fracture. All of these different traditional medical diagnoses that we're going to be working on the rehab. So can you explain a little more how that integrates with the concept of a movement system diagnosis?
Sure. I mean, I think very, very easily and to the point. What is the most common reason why people have a herniated disc? Flexion rotation. So by and large, the majority of people that have a herniated disc with radiating symptoms have a flexion rotation problem, and they're usually young. What are the conditions of spinal stenosis, spondylo? What aren't you going to do? You're not going to extend them because extension is the problem. Do you understand? So, and again, in fact, I'm not. My interest in diagnosis is so strong. If you were a McKinsey person, you'd be making them extend more because they're flexed. I just want them not to flex, for the herniated disc kind of problem. But there's a complete parallel. Most people are using some direction-specific information.
What about the more traumatic diagnoses?
Like?
Well, like somebody just tears a tendon. So.
Well, I mean, that's okay, and there are we have tissue-based things, so you step them through. What are the majority of patients we see? They're not traumatic patients. The majority are the people that have progressive pain over a long period of time. They're not the big accident.
I mean, how do I, trying to incorporate the concept of a movement system diagnosis, and in a sense, what's unique to us as professionals, but yet if we are going to treat a large number, depending on the type of practice you're in, of these diagnoses which are not unique to us, which are part of, say,
I don't see where the problem is, Peter, because so I have a patient who has a diagnosed herniated disc with an L5 radiculopathy, and I call him a flexion rotation patient because my treatment is I'm not doing anything to that disc. What I'm doing is correcting the mechanics that are creating the additional trauma for that disc. So why shouldn't I spell out clearly what my strategy is for treatment? I will say, I've done the rounds for the neurologists and neurosurgeons at our place, and they were like so happy to get this framework of what we were doing. Because as you know, if you send somebody to a physical therapist, there are no rules. I mean, if they want to cook them to death or freeze them or pray over them or pummel them, they can.
So the movement system diagnosis may be parallel and coexist with
Absolutely.
The medical
it's
diagnosis.
Not an either-or. It's complementary. It's complementary. Right. And what's the nice thing? How many do you get? There is no diagnosis. Back pain? Degenerative disc disease? What does that mean? You're old. Not even that old. Not even that old. No, it's a way to organize. It's a way to build a strategy. It's a way to let people know we figure things out. And I just think that is so critical. So critical. And I'm not making all of these diagnoses can be made by clinical exam. By clinical exam.
Thank you very much.
You're welcome. Yeah.
Hi, thanks for the great presentation. You're very funny. It was great.
Well, the entertainment, if not the education, right?
It seems to me most of the patients you see, you treat them like 2-3 times over a long period of time. So it seems to me you're able to be very effective when you see them and instruct them, then they're able to carry those out. So once in a while you see a patient who is basically a total mess. Like you have somebody coming with pronated foot, maybe femoral interversion, tibial lateral rotation, varium of the tibia, maybe they have SI problem, a little bit thoracic stiffness. So you're like, okay, where do I start? You identify all those, and you have to figure out which one causes which. And do you have an algorithm, like you like to go from bottom up or top down? Or
No, I like to go from where it hurts.
what if they have multiple pain locations?
Well, you know, quite clearly, if it is multiple, I'll say, which one? I have one right now, and she's got all this upper body pain, but the thing that's really doing her in is the low back pain. Mm-hmm. So, and part of, you know, my whole exam is looking at people as a total biomechanical entity. I don't say, like, let's look at L5. I'm looking up and down the kinetic chain, because it is a biomechanical interactive system. You all are proving that in spades. Mm-hmm. So I'd say, if your back is really hurting here, let's teach you how to move so that it doesn't hurt your back. And you know what? If you get a back and a head like this, do you know when you straighten them out, like, both things start to get better? Do you know what I mean? Because you're putting the whole system back at one time. So I start with what's bothering them most, show them how to be in charge of that. And as I say, because you're really dealing with the whole body as such, the other things start to take shape, and then you can concentrate as the system allows.
So you kind of use pain as a guidance when you provide the treatment. You can let me address the back. If the back pain, if I address the back, the pain goes away, and then that's where I start. Sure.
I mean, and it's to them, what's really interfering in their life the most? What do they need to change the most? And that's where you start to work. Yes, and just teaching them what to do and how to be in charge of it, how to change those patterns. They usually all play together.
Thanks.
Okay. Okay. Yes.
Well, this was a great start of the Kaleckas lecture series. I couldn't have chosen a better person.
I'd like to say one quick
thing.
Yeah,
sure.
Mr. Kaleckas is going to see or hear this later.
He is actually in Paris.
Yeah, I know, but I mean later he's
going he's going to see this.
Because I just want to tell him one of the things that I was so excited about with Mr. Kaleckas sponsoring this is that I kind of suspected that name was Lithuanian. I think that's true, isn't it? Well, I've kind of looked it up because I'm very Lithuanian, and so yeah, I know the name is Sahrmann, but that's all misleading. I'm really kind of Irish Lithuanian. I mean, a German with a sense of humor. No. Anyway, so I was doubly delighted that this had sort of a Lithuanian connection. That I just wanted to say.
So we'll talk to Richard when he comes back. And so I wanted to thank a few people here, because this was not only great that Shirley could help us, but I also wanted to thank Dr. Gail Huber for helping us organize these events. She really helped us do a lot of the work here. Also wanted to thank our colleagues from the Development Office of Feinberg School of Medicine, more specifically Alex Casilius and Jeff Neerhoef, who have been instrumental in bringing this all about as well. And last but certainly not least, I would like to thank Mr. Richard Kaleckas, as well as Ann Kaleckas' friends, who are right here with us. Because without them we could have never achieved this. So thank you very, very much for your contributions. Thank you. And I've been asked by Gil to make a final announcement, and that is for those of you that are looking for continuing education credits. If you go outside the door in a moment, you can walk to the left. There are tables with paperwork, and you can get paperwork that basically will confirm that you have been here and followed this great lecture of Dr. Sahrmann. So thank you all for being here tonight, and hope to see you in a year from now. Thank you.